This call is now being recorded.
Bismillah ar-Rahman ar-Rahim. I am Dr. Abu Omar, and today is the first day in our revision course for September 2026 exam. We will start with Fawzia sheet, and this is the first meeting in Fawzia sheet discussions. We will start with Dr. Hanan with the first question. Start, please, Hanan.
The pressure within the pleural space is negative with respect to atmospheric pressure, except for which of the following? A, at the end of expiration, B, at the end of inspiration, C, during the Valsalva maneuver, D, if the patient has a tracheostomy, E, when taking a deep breath. Answer is C, during the Valsalva maneuver.
Okay, so do you know what is the Valsalva maneuver?
Yes, it's forceful exhalation against a closed glottis.
Excellent. Yes, this is a Valsalva maneuver. So the key word in the question is the pleural space is negative with all of the following except. So we mentioned before the extreme words or the confusing words in the questions. Please try to pick these questions because this is the key to answer the question. Okay? If you didn't notice this word except or most or least or all this most or what is the first, what is the initial, what is the definitive. These words are very critical to know the answer because it will change the answer directly. Okay, so here they mentioned that all negative except. So the other form of the question, which one is positive? This is a new question. If I ask you which one of the following is positive, you know, this is a real example how they can change the question, but it's the same information. Okay, guys? So the question is, what is the positive pressure related to or in respect to the atmospheric pressure? And as she mentioned, during Valsalva maneuver. Okay, so normally, the intrapleural pressure is negative. Okay, in all phases of quiet breathing. In quiet breathing, all phases of quiet breathing, the intrapleural pressure is negative with respect to the atmospheric pressure. Okay? Normally, in quiet breathing, it's continuously or always negative in all breathing phases of quiet breathing. But with Valsalva maneuver, this is not quiet breathing, so it will be positive. Okay, okay, Hanan?
Yes.
Okay. So all other phases will be negative. And this is the only one positive. Okay? Okay. So here we will also discuss some details about surfactant. Do you know what is a surfactant, Yahnan? And synthesized by which cell? What are the cells synthesize the surfactant?
So it's synthesized by the alveolar cells. Another name would be type 2 pneumocytes.
Yes, excellent. Type 2 pneumocytes. And consists of what?
Phospholipoproteins.
Excellent. And what's the function?
The surfactant lowers the surface tension in the alveoli to prevent atelectasis or collapsing of the lungs.
Excellent. At the end of expiration, why the alveoli not collapse? This is the alveoli with air, and after expiration, the alveoli should reduce in size. Why it's not collapsed like this? Due to surfactants. Okay, the surfactant prevents the collapse at the end of expiration. Okay. Okay, Hanan. Next one. Any question here? Anyone has any question? Okay, next one, yeah, Hanan.
A 30-year-old alcoholic man presents with acute severe upper abdominal pain and vomiting. He is admitted to the intensive therapy unit with a diagnosis of severe acute pancreatitis. 48 hours later, he develops peripheral paresthesia and carpopedal spasm. The most likely underlying metabolic abnormality is A, hypercalcemia, B, hypernatremia, C, hypocalcemia, D, hypokalemia, E, hyponatremia. The answer is C, hypocalcemia.
Hypocalcemia. Why?
Because usually after developing pancreatitis, you get hypocalcemia, and the symptoms, the peripheral paresthesia and the carpopedal spasm corresponds to the hypocalcemia.
Excellent, Habibi. So, why we will select hypocalcemia? We have two ways to prove this is the answer. First of all, the fact that what is the relation between pancreatitis and the calcium level? Pancreatitis and the calcium level. Pancreatitis will lead to hypocalcemia, and hypercalcemia will lead to acute pancreatitis. This is the relation, the fixed relation. If the patient developed pancreatitis first, then the complication of pancreatitis will be hypocalcemia. Okay, this is a separate relation. On the other side, if the patient has hypercalcemia for any reason of hypercalcemia, the patient will develop what? Pancreatitis.
Yes.
Okay, so it's a separate relation between calcium and pancreatitis. Pancreatitis will lead to hypocalcemia, and hypercalcemia will lead to pancreatitis. Here, the patient has symptoms of pancreatitis, okay? And already it's mentioned very clear, severe acute pancreatitis. If I am examiner, I will delete this and I will put the picture of acute pancreatitis to make it more difficult. And this is what will happen in the recent exam. Okay, here they are kind and they give you clearly the diagnosis, okay, of acute pancreatitis. And also they give you the symptoms of hypocalcemia. So you will know the relation between pancreatitis and the calcium, and you will know what are the symptoms and the presentation of hypocalcemia. So if you read these symptoms, even you don't know this relation, you will not select hypercalcemia or hyponatremia. So even if you don't know this rule, from the symptoms, peripheral paresthesia, carbopedal spasm, if I ask you directly, patient with carbopedal spasm, without any details or history, you will say hypocalcemia. Okay, guys? So I need your mind to be broad and thinking widely, not only focused with single word in the stem. Okay, so from the presentation and diagnosis of pancreatitis, and also from the symptoms and the clinical picture of hypocalcemia. Okay, so symptoms of hypocalcemia, here they mentioned only the peripheral paresthesia and the carbopedal spasm. What other presentations of hypocalcemia, Hanan?
Cardiac.
You can change the presentation and put another symptoms. Okay.
Cardiac arrhythmias. They can develop chopstick sign, trizor, I don't know how to say it, or trizor sign. They can develop oral and perioral paresthesia, laryngospasm as well.
Yes, excellent. So to summarize them and classify the symptoms, the hypocalcemia presentation called tetany. And this tetany may be manifest or latent. Okay, manifest means the patient come to you with the presentation, with the symptoms. Okay, you will look the patient carbopedal spasm and some muscle cramps and muscle pain and maybe suffocation if there is laryngospasm or stridor, something like this. The patient come with the manifestation. This is manifest tetany. From the first look, you will say this is hypocalcemia. Okay, or from the history and from some background about the patient, or if you know the patient has pancreatitis already, then you need to confirm if the patient has latent tetany. Latent tetany, the patient apparently is normal, no problem, but you need to provoke the symptoms of tetany. Here we have what is called latent tetany. How to provoke it? We have two signs, Troisier signs and Chivostic sign. Chivostic sign and Troisier sign. Okay, Troisier sign is carbopedal spasm. How to do carbopedal spasm in this patient? By inflating the cuff of the sphygmomanometer around the blood pressure above systolic. Above systolic, the patient will develop carbopedal spasm. This sign called Troisier sign. Okay, the other sign is Chivostic. You know it, ya Hanan?
Yes, when you tap on the cheek, you notice some twitching.
Yes, on the cheek. So Chivostic, Chivo cheek. Remember by this. Chivostic on the cheek. Okay? This is the latent tetany. What is the life-threatening complication of hypocalcemia?
Laryngospasm.
Excellent. And the cardiac arrhythmia. Okay?
Yeah.
But laryngospasm more severe because this is suffocation. But cardiac arrhythmia may be fatal in some cases. So now we remember we mentioned the relation between pancreatitis and calcium level. So we need to explain why pancreatitis or how pancreatitis cause hypocalcemia and how hypercalcemia will cause pancreatitis. Do you know the mechanism or the how it will happen?
Maybe I know a bit. So with hypocalcemia, usually we have hypoalbuminemia, low albumin, and that would lead to low calcium. That
No,
would
no.
give us
Again. Repeat. With hypocalcemia,
la, sorry, with pancreatitis, we have low
aywa, yes,
albumin,
yes.
and that would, as a result, give us hypocalcemia, as the calcium and the albumin would bind together.
You start with the least important, not least, with, this is not the most important mechanism. What is the most important mechanism of hypocalcemia in pancreatitis?
Saponification, but I don't know how to explain.
Excellent. Yes. So, can you explain what is the saponification process?
I'm not very sure.
Daya, you know?
I'm not sure.
Sap-
I know
okay.
saponification. That's
Okay, so what is the saponification? As we know, in acute pancreatitis, there is release of pancreatic enzymes. One of these pancreatic enzymes is lipase and amylase. Okay, lipase will make destruction of fat and triglycerides and mesenteric fat surrounding the pancreas and all this. This will make release of what? Of free fatty acid. This free fatty acid will bind with calcium, okay, forming calcium salts. The free fatty acid, after action of lipase, the free fatty acid will bind with calcium, forming calcium salts, and this will lead to hypocalcemia because this calcium, it's already in the body. It's not excreted outside the body, but it's not functioning, not working. So there is calcium, yes, in the contents, in the general content, it's already present, but it's not effective. The effective one is the ionized calcium. This one is calcium salts, not ionized. So it will give symptoms. Clear? This is the most important mechanism how pancreatitis will cause the hypocalcemia. Okay? The other mechanism, as you mentioned, in pancreatitis, there is hypoalbuminemia, and also this will lead to low ionized calcium. This is another mechanism. The third mechanism is in pancreatitis, there is enzymes and toxins in the blood. These toxins and these enzymes will cause inhibition and the destruction of parathyroid gland. So there will be low parathyroid hormone, and this will lead to what? Low calcium level. We will discuss the parathyroid. I think today we have one question about the parathyroid, hyperparathyroidism, and all this. Okay, but this is one of the mechanisms. We have a three mechanism how pancreatitis cause hypocalcemia: calcium saponification, hypoalbuminemia, and pancreatic enzymes suppress and destruct the parathyroid gland, causing hypoparathyroidism, causing hypocalcemia. On the other way, the hypercalcemia can cause pancreatitis. What is the mechanism, ya Hanan?
As usually, calcium would deposit in the pancreatic duct
Yes, excellent.
because calcium is a cofactor for pancreatic enzymes.
Excellent. Help in activation of pancreatic enzymes and also deposited in the ducts. Yes, this will cause pancreatitis in case of hypercalcemia. Okay. What other causes of hypocalcemia apart from pancreatitis? Hypocalcemia. Now, patient with hypocalcemia. Pancreatitis, one of the causes, but it's not the only one.
Sorry, just give me 1 second. I'm thinking. I didn't think of it.
1 second, boss, ya Hanan.
Okay.
1 minute. Okay.
What are other causes?
Yeah,
Okay,
Shostak and Tresal. Shostak and Tresal signs are like symptoms of hypercalcemia.
No,
are you asking about symptoms or causes?
no. I asked about causes of hypocalcemia.
Or causes.
And yeah, sorry.
Hyperparathyroidism.
Yes, one of them. We just mentioned, Hanan, hypoparathyroidism is one of the causes.
Hypomagnesemia.
Yes,
hyperalbuminemia,
yes, chronic renal failure,
renal
vitamin
insufficiency.
deficiency, or hypocalcemia drugs of hypercalcemia, like bisphosphonate therapy. These drugs used for hypercalcemia. Overdose will lead to what? Will lead to hypocalcemia. Also, in case of not malignancy, chemotherapy, okay, will lead to also hypocalcemia and some diuretics. Okay, the last step, ya Hanan, in this discussion is the effect of calcium level high or low on what? On the ECG. Do you remember?
The
Effect of hyper or hypocalcemia in ECG.
hypocalcemia causes prolonged QT interval and
Prolonged. Yes,
prolonged ST segment.
excellent. And hyper?
I'm not sure. Probably the opposite. I'm not sure.
The opposite, yes. It
Ah,
will make the same.
sorry. Short QT.
Yes, because
Ah,
how hyper and hypo, both of them will make the same effect. It's opposite.
yes.
Okay? Yes. So hypo will lead to prolonged, hyper will lead to short.
Short.
Okay? So I have a point here to remember, to not forget. We know that the calcium important for contraction. Okay? Okay, and contraction is the strength and the power. So if you have the same action, and this is something you need to do, and we have one strong man and one weak man. The weak one will take longer time to make the same action, and the strong one will take short time to make the same action. You got my point? Okay.
Yes.
So calcium generally related to the strength of contraction, the power of contraction. So with high power of contraction, it will take short time. Okay?
Yes.
With low calcium, weak contraction, it will take long time. So prolonged QT and ST with hypo and short in hyper. Okay? Okay, excellent. Hanan. We have finished this question, all discussions related to this one. Next one.
Okay. A 50-year-old woman attends her GP due to a change in appearance. She finds difficulty removing her rings, reports an increase in shoe size, and photographs reveal a change in her facial appearance. Visual field tests are performed to direct confrontation. Which of the following defects is most likely to be associated with her presentation? A. Binasal heminopia. B. Bitemporal heminopia. C. Homonymous heminopia. D. Inferior quadrantopia. E. Unilateral loss of vision. The answer would be B. Bilateral heminopia.
Not bilateral, bitemporal.
Bitemporal, sorry.
Okay. Bitemporal hemianopia. Okay.
Yeah.
I think in the open discussion we discussed this question and what are the visual field defects, but we will revise here again. Okay. So what do you understand from the presentation, ya Hanan? This patient has what?
A pituitary adenoma?
Yes. How you know it's pituitary adenoma?
Because of the findings, the signs.
Yes. The findings or the presentation with the acromegaly. This is
Yeah,
a
sorry.
case of
That's the word.
acromegaly. Acromegaly is a finding or the syndrome or the presentation of increased growth hormone. Okay, so this patient has increased growth hormone and this facial changes and hand changes. All this due to excess growth hormone, which come from pituitary adenoma. This pituitary adenoma will make the pituitary gland increase in size. What is the critical structure directly related to the pituitary gland is the optic chiasm. Optic chiasm. So I will revise what we mentioned in the open discussion meeting related to the visual field and the presentation of the vision on the retina and then on the CNS. Okay, as you know, in the visual mechanism, everything is reversed. The upper part of the field will seen in the lower part of the retina, and the lower part is the upper part, and the medial one will be in the lateral, and the lateral one will be in the medial. Everything, like the lenses, everything will be reversed. Okay, this is one thing you need to keep in your mind. The other thing I like to say here is this is one retina, and this is the other one. This is the optic nerve, and this is the other one okay? And they will be near to each other. Actually, in the meeting or the crossing point of the two optic nerves, the fibers, not all fibers will cross. Not all fibers will cross the middle line. So say this is the one and this is one, okay? And this is the optic nerve like this, okay? So the medial fibers only will cross, and the medial fiber of the other side will cross. The lateral fibers, the outer fibers, will continue in the same side. Okay? I hope the point is clear. The medial fibers of the optic nerve, the medial half of the fibers of the optic nerve will make the crossing in the optic chiasm. This is the optic chiasm. Okay? So what is the optic chiasm? Optic chiasm is the crossing of the medial fibers of both cranial nerves. Lateral fibers continue without crossing. So if I make any problem here, any compression or any damage here, it will affect the medial part of what? Of the retina. We will not say the medial actually, we will say the nasal, because the nose here in the middle. So this inner half called nasal, and this inner half called nasal, the outer half called temporal, related to the temporal bone on the side of the skull, and this one is temporal part. Okay, as we said before, the temporal half of the retina responsible, the nasal half of the retina responsible for the temporal part of the visual field, and the other nasal part related to the temporal part of the visual field in the atmosphere. Nasal part of the retina will see the temporal part. Okay, so if you damage both nasal parts of the optic nerve, the both temporal parts will, in the visual field, will be affected. So it's called bilateral temporal half of the visual field. Hemi, because it's half of the visual field. Hemi is the half. Anopia means blindness. So the patient is blind half of the visual field, the temporal half on both sides. Why on both sides? Because we damage the crossing point of the medial fibers of the optic nerves together when they cross each other. Clear, everyone? Any confusion here? Hello?
Yes, sir. Understood. Yes, sir.
Yes, clear.
So this is the pituitary adenoma and effect of pituitary adenoma on the optic chiasm. It will cause bitemporal hemianopia. If the lesion of the visual pathway is before the optic chiasm, what is the result, ya Hanan? I cut here the optic nerve. What will be the effect? Hello, Hanan?
Hi, sorry. It would be, we've had it before. It would be unilateral something.
Unilateral what?
Total
And-
blindness.
Oh, okay.
What, ya Sahar? What you say? Unilateral what?
On the same side of the cutting, there will be blindness, temporal and nasal fields.
Yes. It's called monocular vision loss.
Yeah.
Okay, monocular vision loss. You understand? It's okay. This is enough to know that you understand. Okay, the vision in this eye completely will be lost, but the other eye is okay. This is before the crossing point. In the crossing point, we already discussed, and in the optic tract after the optic chiasm, it's called optic tract. In optic tract, what is the effect? It will cause homonymous hemianopia. Homonymous hemianopia. Okay, and in the temporal loop lesion after the optic tract, it will give optic radiation after the optic tract. If the lesion in the optic radiation pass through two lobes of the brain, temporal lobe and the parietal lobe. The optic, so again, what are the steps? We have optic nerve, then optic chiasm, then optic tract. After optic tract, there is optic radiation. This optic radiation passes through temporal lobe of the brain and parietal lobe of the brain. Okay, optic radiation in temporal loop and the parietal loop, because it caused radiation, long radiation, until it reached what? The occipital loop of the brain. Okay, so it will pass through temporal and the parietal loops of the brain. Okay. So we here mentioned the optic nerve, the effect of optic nerve, optic chiasm, optic tract. In optic radiation, we have temporal loop, part of the optic radiation, and the parietal loop contains some of the optic radiation. If the lesion in the temporal loop, or what will be the effect, and if the lesion in the parietal loop, what will be the effect? Remember this mnemonic: PITS, PITS. Remember this word, PITS. What is PITS? As you know, P for parietal, parietal inferior, temporal superior, parietal inferior, temporal superior. Inferior what and superior what? Quadrantanopia. Homonymous quadrantanopia. One, if this is a visual field of one eye, okay, it will be 1/4 only affected, 1/4. So it will be, if the lesion in the temporal, as you know, TS, BITS. TS means superior quadrantanopia. Okay, if the lesion in the parietal, PI, parietal will be inferior. Parietal means inferior and temporal means superior. Okay, I know you will say the temporal bone is inferior to the parietal bone, and we said before, everything is reversed, everything is upside down, nothing will be straight. So parietal loop or parietal loop of the brain higher than the temporal. So parietal loop will responsible for inferior vision, quadrantanopia, loss of quadrantanopia. Okay, and the temporal will be superior. Just remember PITS and you will know it. Parietal loop lesion will lead to inferior, temporal will lead to superior. Okay? Okay, Hanan?
Yes, thank you.
Everyone understand this? Okay, I will add another thing related to pituitary adenoma to cover all related questions to this part regarding the tumors affecting the optic chiasm. Again, remember the rule that we mentioned, everything is reversed. Everything is reversed. So if this is the optic chiasm, okay, to simplify the diagram, this is the crossing part of the medial fibers, optic chiasm. Below it is the pituitary gland. Okay, so with the tumor or adenoma of pituitary gland, it will grow up like this from down upward, affecting what? The optic chiasm. Okay, we have another tumor. There is another tumor also affecting the optic chiasm, but from above.
Craniopharyngioma.
Excellent, ya Hanan. Craniopharyngioma. Okay, from its name, it's come from cranio means cranium, which is the skull. Cranium, skull. Going toward the pharynx, which is lower than the skull. So it's coming up from upward downward like this. But pituitary, because it's lower than the chiasm, it will grow upward, because below the pituitary there is bone. Okay,
Yeah.
what is the name of this bone, ya Hanan?
Sella turnica.
Excellent, ya Hanan. Sella turcica. This is a bone below the pituitary. This is the cave that carry or holds the pituitary gland. It will not grow below, okay, but it will grow upward. So pituitary adenoma will grow up, affecting the optic chiasm. Craniopharyngioma will grow downward, affecting also the optic chiasm. What is the difference, ya Hanan? Do you remember? Do you know what is the difference?
The visual field, the part of the visual field that's affected. So the pituitary adenoma will affect the upper part of the visual field, while the craniopharyngioma would affect the lower part of the visual field.
Mostly correct, but still confusing for some of our friends. Why? Both of them, remember, both of them will lead to bitemporal hemianopia. Okay, again, any lesion in the optic chiasm from below or from above will lead to what? Bitemporal hemianopia. Okay? No way. This is the effect. But how to differentiate? Okay, let's say patient has pituitary adenoma. This is one visual field, and this is the other visual field. This right eye, for example, and this is left eye, and this is the nose here, and this is the temporal half, and this is also the temporal half. The patient with optic chiasm problem has this half affected. Okay, that we explained already. Okay, patient with pituitary problem, the bitemporal hemianopia will start from above. How? It will not be sudden. It's not sudden. It's not switch, closing the light or open the light. Not like this. It's gradual because this is a tumor growing and affecting gradually, not sudden cutting by trauma, like trauma. It's not trauma. It's a tumor. Okay? So the pituitary problem, pituitary adenoma, slowly growing, the problem will start in the upper part of the temporal half. But when it grows, it will continue to make full bitemporal hemianopia. Or so the patient will say, my visual loss starting in the upper part of the temporal half, okay? Start with the upper part of the temporal half. Or they can say the upper part is completely blind, but the lower part is still, I can see something. Severity is in the upper part. Or the problem start in the upper half of the temporal part, temporal half. Okay, this is the pituitary. If the patient says the opposite, that the problem starting from the lower part of the visual field or the lower part of the temporal half more severe than the upper part of the temporal half, this means it's craniopharyngioma. Okay, guys? I need everyone to confirm, please. Is it okay?
Yes, sir. Yes, sir. Yes, sir.
Yeah.
Because, okay.
Yeah.
I don't like to skip any difficult point, but still I need to confirm it's clear. Okay, so we have done this question. Alhamdulillah.
Alhamdulillah.
Okay, Hanan, next one.
Okay. A 24-year-old man falls off his motorbike, fracturing one arm, both femurs, and rupturing his spleen. He required surgery and 20 units of blood. 24 hours after admission, he has passed 350 ml of urine. His blood pressure is 90/50, and he has low skin turgor. Which of the following best describes the changes in the renin-angiotensin system initiated at the juxtaglomerular apparatus in this patient? So, when answering this question, we'd go first with the renin concentration, and then I would choose whatever's the arrow going upwards, so either C, D, or E. And then the angiotensin concentration, which we'd expect to go up, so the answer would be E here in this question.
E.
Yes.
Okay. Yes, excellent. I will give advice in this type of question, this form of questions with 5 options, yes, and each option has 3 parts or 4. Some question has 4 parts. In this type of questions, especially in ABG questions and some neurological effect, some question form is like this. It's not just a simple information. It's a complex with the 3 parts. The golden advice to deal with this question is to go vertically, not horizontally. Why? If you go vertically, descending in the first column, you can exclude some options from the first column only. So, for example, if I exclude the first part of the first option, I will not read this one. Okay? So, as we know, this patient has increased renin. So, from the first step, I know the renin will be high. The renin will be high. Directly, I will exclude this and this. Okay? Renin here low, here renin low, exclude this. Do you have to read this one? No. You will not read this one. You will not think, what about angiotensin? What about aldosterone? No. These 2 options completely exclude. Then we will talk about what about the angiotensin 2. Angiotensin 2, if renin increase, angiotensin 2 will increase. So here, this one is wrong, this one is wrong, this is the answer. You will not read any part of the 3rd column. No need. Okay? If you go descending in the first column, you will save more time and confusion. Because from the first column, you exclude, then from the second column, you exclude some options, then you can find the answer very easily. Okay? This is the advice for many questions by this form. Okay, so let's discuss the scientific part of the question. This patient presentation has What are the presentation of the patient, ya Hanan?
Hypovolemic shock. So he was presenting with low urine, 350 mils of urine output. His blood pressure was low, so hypotensive, and low skin turgor.
Yes, so this is the features of bleeding, hypotension, because the patient already has fracture and RTA, so there is hypovolemic shock. What is the sequence of hypovolemic shock? What will be the response for this one? We need to save life of the patient, so we need to raise the blood pressure as possible. This is the natural response. So hypovolemia or hypovolemic shock or or hypotension will lead to stimulation of renin. Renin come from where, ya Hanan?
Renin is from the juxtaglomerular apparatus.
Cells. Excellent. So every single word in the RAS system come in exam. I am not exaggerating, okay? Every single information and word in RAS system can become in exam and asked already. So please don't skip or ignore any one word in our discussion. I will cover all questions came before about RAS system, and even in recalls you will find more questions about this. Okay, so please focus with me and follow our discussion. So renin come from where? Juxtaglomerular apparatus cell of the kidney. Angiotensinogen come from where?
The liver.
Okay, ACE enzyme, angiotensin converting enzyme come from where?
The lung.
Lung and the kidney, but lung is the main one. Okay, aldosterone come from where?
The zona glomerulosa.
Excellent, yes, excellent. So zona glomerulosa of the liver, right?
Of the adrenal gland.
Yes.
Ah.
Zona glomerulosa of what?
Of the adrenal gland.
Of adrenal cortex.
Cortex.
Okay, so we have adrenal gland, has medulla and the cortex. The medulla in the middle and the cortex is 3 layers.
Yeah.
The word zona means layer. Zona, three layers. Zona glomerulosa, zona glomerulosa. The middle one is zona fasciculata, and the inner one is zona reticularis. Okay, 3 zona in the adrenal cortex. Okay, adrenal gland or suprarenal gland cortex has 3 layers. Medulla in the center, in the middle. This is the core of the gland. Okay, so each zona has a specific hormone to secrete. Zona glomerulosa is the outer one. Secrete what? Secrete aldosterone.
Aldosterone.
Aldosterone, which controls the salt, the sodium. Okay, and the middle zona is zona fasciculata. Control what?
Glucocorticoids.
Yeah, this is glucocorticoid and control cortisol and control sugar. Okay, can cause hyperglycemia and diabetes. Zona reticularis, the inner one, secrete what?
Androgens.
Androgens. Okay, one type of androgen. Okay, which is the sex hormone. Okay, these are the 3 layers. The medulla secrete adrenaline and epinephrine and norepinephrine, or adrenaline and noradrenaline. Now we know the site of each secretion and the name of the secretion of each part. Renin, angiotensinogen, ACE enzyme, aldosterone, cortisol, and sex hormones. Okay, this is first part. Everything asked, all this. Okay, so what is the stimulus of renin production? We just mentioned some.
Hypovolemia, hypotension.
Yes,
Hyponatremia.
Yes, hyper what?
Hyperkalemia.
Excellent. What else?
I'm not sure.
Erect position, erect posture. Okay, standing. And also sympathetic stimulation. Okay, how sympathetic raise the blood pressure? One of the mechanisms is stimulation of renin. Okay, so to revise the sequence very quickly, and I advise everyone to watch the record of RAS system. We have RAS, a short video in the website about RAS system, 15 minutes, will cover everything if you like. But to summarize it, we have a substance called angiotensinogen, okay, come from the liver. Then it's already present in the blood, but it's not active. Then with the stimulation of renin production, renin will come. Renin will act on this one to produce angiotensin 1. Angiotensin 1 will be angiotensin 2 by the effect of what? Of ACE enzyme, angiotensin converting enzyme. This converting of angiotensin 1 into angiotensin 2. This enzyme convert. So it's called angiotensin converting enzyme from 1 to 2. Okay? And this enzyme again come from liver. From lung. Okay? This is the steps, step by step, until we find the main joker. This is the Ronaldo of the system. Okay? So it will make many actions, and this is the most important one. Okay? This is the main player in all this. So all these materials and substance not effective. Not effective means not make a proper action. So I can't say what is the action of angiotensin 1, what is the action of renin. All of them are servers to give us the main player of the system, which is angiotensin 2. Okay? So in renin also we have two MCQ, very common. What is the substrate of the renin? What is the renin substrate, and what is the renin product, ya Hanan? Do you know?
Yes, the renin product is angiotensin 1. The substrate is angiotensinogen.
Excellent. Yes, this is question come like this. Substrate means what is the meaning of substrate? Renin substrate means what is the substance renin will act on it. What is the renin product means what is the substance will be produced with the renin action. This is the product. The production of action of renin will be angiotensin 1. These two MCQ also common. Okay, then we need to know what is the function of angiotensin 2. Now we have angiotensin 2. What it will cause, what it will make?
Vasoconstriction.
Vasoconstriction. Everything can cause vasoconstriction. We say this is Ronaldo of and Messi of the last system. It will make many actions. Okay, vasoconstriction is one of them. Yes, it's correct. I'm sorry, it's correct, but it has many other actions. What else?
Increase sodium absorption.
Excellent, yeah, Sahar. But I will give you the key to remember everything about angiotensin 2. Okay? What's happening? I don't know why the pencil not acting. Sorry, what happened?
I don't think it's charged.
Oh, the pencil not charged. So sorry for this. Yes, but the iPad already charged. Okay. Sorry for this, but I will try to continue without the pencil. So what happened? When you talk about the angiotensin, you need to summarize the action by two levels. What is the site? What is the action, and what is the mechanism of action? Okay, again, angiotensin. We need to know the functions of angiotensin 2 by three information. What is the site of action, and what is the action, and what is the mechanism of this action? I will give you an example. Hanan mentioned vasoconstriction. Okay, yes, correct, vasoconstriction. This is the action. Okay, what is the site of action? Arteries.
Artery.
Yes, so the site is the artery. The action is vasoconstriction. What is the mechanism? How angiotensin 2 cause vasoconstriction? This is the mechanism. How? By two mechanisms. Whether by direct action, so angiotensin 2 itself is vasoconstrictor. It will cause vasoconstriction. And the other mechanism is by stimulation of sympathetic release of noradrenaline. Okay, so the action is vasoconstriction. The site, vasoconstriction of the arteriole, of course. Okay, what is the mechanism? Direct action, and by the other mechanism, by what? By stimulation of sympathetic. Okay, the next function, the next site of action is renal tubule. Renal tubule, as Sahar mentioned, in renal tubules, it will increase sodium reabsorption and the potassium excretion. Okay, with the sodium reabsorption, there will be absorption of water. The patient has hypotension, hypovolemia. We need to reabsorb more water and prevent the fluid loss. So how to make this? Absorption of sodium in exchange with potassium, and the water will follow the sodium. Okay, to keep the blood pressure. Sodium will raise the blood pressure and water as well to compensate the hypovolemia. Okay, so what is the site of action? Renal tubule. What is the action? Sodium reabsorption, potassium excretion, and water reabsorption. Okay, so you can say sodium and water reabsorption and potassium excretion. This is the action. What is the mechanism? Again, the mechanism is direct mechanism by itself. It can make this action directly by itself, or also by stimulation of what? Of aldosterone. Okay, Hanan?
Yes,
Okay, aldosterone come from where?
from the zona glomerulosa of the adrenal cortex.
MashaAllah. Excellent. Okay, or by direct action. This is the next function, electrolyte and water effect. Okay, another action on the glomeruli. On the glomeruli, it will reduce the glomerular filtration rate. So if you reduce the glomerular filtration rate, so you will also reduce the loss of fluid from the glomeruli. Okay, this is the action and site of action, and it will cause it directly. Okay, also on the CNS, it will stimulate production of antidiuretic hormone. Okay, so it will stimulate production of antidiuretic hormone, and it will stimulate something called thirst mechanism. Okay, thirst, stimulate thirst. So when the patient feels thirst, the patient will drink water. It will increase water intake. Okay, so one of the mechanisms why you drink water because you feel thirst. So this is one of the mechanisms. You need to drink to raise your blood volume and all this. Okay, so on the CNS, it will stimulate thirst mechanism, so increase water intake, and it will increase the antidiuretic hormone, which will cause less urine secretion and retention of urine, of water. Okay, this all the actions of what? Of angiotensin 2. Okay, guys? Okay, Hanan?
Yes.
Anything not clear here?
No.
Clear.
Okay, so regarding the antidiuretic hormone, what is the lifespan of antidiuretic hormone? After it's secreted, what is its lifespan? Half-life in the blood?
10 to 20 minutes.
Excellent. 10 to 20 minutes. Okay, 10 to 20 minutes of the antidiuretic hormone will stay in the blood. This recently come. What is the site of action of antidiuretic hormone?
Collecting ducts, distal collecting tubules, I think.
Yes, excellent, perfect. Okay, and what is the action? It will increase water permeability and increase reabsorption of water. So water retention and concentrated urine. It's antidiuretic hormone. Okay, retention of water and concentrated urine. How it will increase the water permeability and water reabsorption. What is the other action apart from urine concentration and water reabsorption? What is the other action of antidiuretic hormone?
Vasopressor.
Excellent, yes, vasoconstrictor. Okay, the other name of antidiuretic hormone, synthetic antidiuretic hormone called vasopressin. Vasopressin. This is a synthetic antidiuretic hormone. And the natural antidiuretic hormone causes vasoconstriction, which also help in raising the blood pressure. Okay? So antidiuretic hormone is very important. Okay. I think we cover everything related to this one. Yes, I have a mnemonic here also about the site of action. Please remember this one. Okay? I hope this one. Okay, alhamdulillah, now it's working. So regarding the site of actions of the hormones and some substances on the kidney. Okay? We have mnemonic. I think I shared before. I will share now in the WhatsApp group. Okay, follow me while I explain this mnemonic. This mnemonic will cover about 10 questions. 10 questions can be covered by this table, okay, which is a collection. So we have data, SAC, fall, and MAP. Okay, so what is this? Data D for distal convoluted tubule. What are the substance or hormones working on it? Antidiuretic hormone, thiazide, and aldosterone. SAC, C for collecting duct, antidiuretic hormone and spironolactone act on collecting duct. Fall, furosemide on the ascending limb of lobe of phenyl, and MAP, mannitol, and acetazolamide on the proximal convoluted tubule. Every word come before an exam. Every word. So you will, from this summary, you can count how many words, and all these are questions came before. Okay, guys, this is the last thing in this question, and we will go for the last question for you, Yahanan.
Okay. A 35-year-old woman presents to the emergency department with a second attack of painful franchimaturia. What is the most likely pathology underlying this presentation? A. Gram-negative urinary tract infection. B. Interstitial cystitis. C. Renal cell carcinoma. D. Transitional cell carcinoma of the bladder. And E. Urinary TB. The answer is B. Interstitial cystitis.
Sure, Yahanan?
Yes.
Okay. So, why, Yahanan?
Because it was described as a painful, as like something that comes in attacks, and it's and it's painful. So which would be like bladder pain syndrome.
Yes. The other name of interstitial cystitis, please remember, usually remember what is the other name of anything. Okay? So, interstitial cystitis, the other name is bladder pain syndrome. Bladder pain syndrome. You can expect they can remove this one and put another one. This is not a new information. This is a new question. Okay, every time I need to confirm. Some people not study very well and they cry after exam. There are many new questions. Yes, new questions, but not new information. Okay, and to say a new question, to be eligible to say a new question, this means you covered all questions. Then you can know what are the new. You got my point? Makes
Yes.
sense. If I know now we have, for example, 15 person in the meeting. If someone I see him for the first time, I will say he is new, but maybe he joined before, but this is my problem. I didn't see it before. Okay, guys. So don't be scared if you say someone say new questions. Maybe he didn't study very well, so everything will be new. The 300 questions will be new if you didn't study. Okay, so if you study more, you will know the questions easily, inshallah. Okay, so the interstitial cystitis, the other name, as we said, bladder pain syndrome. This is a non-bacterial inflammation. So there is no antibiotic to manage this condition. Okay, the treatment only with non-steroidal and antihistaminic. Okay, so we know it, and also we need to know why. So we have two theory here. Why interstitial cystitis and why not others? So the exclusion concept is very important here to exclude other options. So regarding interstitial cystitis, it's more common in female from 30 to 40. Okay, and it comes in attacks like this, and it's not infective. Why we say not infective? Because with infection there is fever, because there is bacteremia. Okay, but here there is no fever. Any fever in the stem? No. It comes in attacks. This is the second attack. Okay, so this is the positive evidence of interstitial cystitis, but we need to exclude others.
Okay.
Maybe someone don't know about interstitial cystitis or didn't hear about it, but you can exclude. If this is a new for you, you need to know how to exclude other options. Okay, exclude, yeah, Hanan, other options.
So renal cell carcinoma, we'd expect the patient to present with some sort of a painless mass in the flank. And they could tell us about the patient having polycythemia, which
Excellent.
none of this is in the stem.
Excellent.
Transitional cell carcinoma of the bladder wouldn't expect to be in this age group, and there would be more probably like some risk factors involved. Urinary TB, I think there would be TB elsewhere, like there would be a resp, like they would mention something else about TB in the stem.
Excellent. Yes. cough, any sputum, any exposure, risk factor, any nationalities like India or Bangladesh. So they must give you any key for TB. It's not come isolated TB in the urinary system. Okay, so at least they will mention some symptoms or systemic manifestation of TB, or in the history the patient from Bangladesh or India. This will give you a key for TB. Okay, also cough, sputum, weight loss, all this. Okay, so this is TB is excluded. Why not gram negative? Because there is no fever. Okay, and usually the urinary tract infection or any infection, we can't say it come in attacks. Okay, we can't give the description of attacks, because attacks means the disease come in attacks like epilepsy. We can say migraine, it come in attacks. Okay, but if you manage one time urinary tract infection, you will not say when will come the second attack. Maybe it will not come. Some people stay for years without tonsillitis, for example. Okay, so we will not say it's attacks. You got the idea, Hanan?
Yes.
Okay. So the answer will be interstitial cystitis. Okay. Thank you, Hanan. MashaAllah. You
Thank
did very
you.
great, ya Hanan.
Thank you.
Thank you so much. Who is the second one?
Yes, yes, sir.
Okay, Daya. Start, please.
60-year-old man presented with a short history of pain in the right cheek, the right upper teeth. Maxillary sinus infection is diagnosed. This sinus is particularly prone to infection because of water. Option A, absence of ilia and epithelium lining sinus. Option B, closeness to the sinus to the nasal cavity. Option C, pores of supply. Option D, position of the sinus ostium high on the medial wall. Option E, relationship of the front teeth to the floor of the sinus. Sir, option D, position of the sinus ostium high on the medial wall.
Answer is D.
Yes, sir.
Yes, excellent. By the way, this question is pure ENT question, and this one of the most commonly wrong answered question in the free PDF, in the free groups. Okay, all groups may answer another option which is wrong. The answer here is option D. The opposite, the opening, the position of the sinus ostium is high in the medial wall. I will show you very nice picture to understand this one. Okay, please check the WhatsApp group. Okay, this view from side view, we remove the lateral wall of the maxillary sinus and we are looking inside. And the red color in front of you, this is the medial wall of what? Of the maxillary sinus. And as you see, the nose is in front, and this is the sinus, and the opening, the draining opening or the ostium is very high in the medial wall. So it's anti-gravity. It's not easy to drain. Okay, this is the correct answer. Well, why other people selecting front teeth? Some people and many other groups select relationship to front teeth. The same picture that I shared. If you look for the front teeth, there is bone between the floor of the sinus and the teeth, the root of the front teeth. But if you look backward in the molar, it's very related. And as an ENT consultant, we face many cases of like this, impacted roots in the sinus, causing repeated sinusitis. But if they mention the molar teeth, not the front teeth, okay? And with also teeth extraction, we find some complication related to fistula between oroantral fistula between the mouth and the antrum of or the cavity of the sinus. So it's not the front teeth. This is the main cause why this option is wrong, and this is the most commonly wrong answer, common and in other groups. Okay, so what is the final answer? The position, as you check, as you see in the picture in the group. Okay, everyone?
Yes.
Anyone has a problem here? Clear, everyone? Okay. Okay, next one, yeah, Daya.
75-year-old insulin-dependent diabetic man has undergone mecoleptomy. On the first POD, is smelled by mouth on subcutaneous insulin. Maintenance IV fluid infusion with saline IV morphine via patient controlled anesthesia. He is confused after a brief convulsion, has slurred speech, and weakness of his right side. His pulse is 110 per minute, respiratory 25 per minute, BP is 160/95, saturation is 95, room air. The most likely cause of the confusion is sir, option A, hypoglycemia.
Why, Daya?
Because he's insulin dependent patient on nil by move, and also supplements the insulin and maintenance IV with vents. Still, that's the reason why he made it for hypoglycemic episode.
Yes, excellent. So the patient has hypoglycemia again by two mechanisms or by two views. First of all, the predisposing factors of hypoglycemia, and also by findings and the presentations of hypoglycemia. Okay, so again, like the hypocalcemia question we discussed before, predisposing factor of hypoglycemia in this patient. If I give you this history, you will say this patient will develop like this, will develop hypoglycemia for sure. Why? The patient is insulin dependent diabetic, okay, and nil by mouth after surgery, and receiving insulin, okay, and receive saline and without glucose. What do you expect? Hypoglycemia. Okay, how to confirm? The patient come with the symptoms of hypoglycemia: fatigue, pale, confusion, convulsions, slurred speech, and some behavioral changes, visual disturbance in some cases, and finally loss of consciousness and maybe coma. Okay, so the findings, clinical findings, and the predisposing factor all together with the hypoglycemia. Okay, so Daya, we have a common cause, not common, sorry, a famous cause of hypoglycemia, which is malignant, which called insulinoma. You heard about it?
Yes, sir. Yes, sir.
How to diagnose it?
Assessment of C-peptide.
What?
C-peptide levels we have to assess. C-peptides.
Three difference?
C-peptides levels.
C-peptide?
Yes, sir.
No, we have a triad. You know the triad? Anyone know what is the triad for insulinoma?
Whipples.
Excellent, yes, صح. Okay, Whipple's triad. Whipple's triad. What it include, yes,
Sweating, dizziness, and tachycardia, signs and symptoms of hypoglycemia, gastric ulcers.
This all?
And increased C-peptide measurement, I'm not sure.
All what you mentioned is one of the triad. You know, we have three things: 1, 2, 3. All what you mentioned is the symptoms of hypoglycemia. Yes, you mentioned it. But we have, what is that number 2 and number 3? Number 2 is blood glucose level, okay, very low. Why we put both of them? Maybe the patient has symptoms of hypoglycemia, but the blood glucose is normal. Okay, maybe the patient has low blood glucose without symptoms. Maybe. So in Whipple's triad, we need both of them: symptoms of hypoglycemia and the low blood glucose level. Together, both must be by clinical and lab. Okay. So what is the blood glucose level here required? To be less than 3 millimole per liter. Less than 3 millimole per liter. This is the second part of the triad. The first part is the clinical. The first point is the clinical presentation of hypoglycemia. The second part is concomitant or associated low blood glucose level. Okay, less than 3 millimole. What is the third part to confirm the diagnosis of insulinoma? What is the third part? Do you know, Yazan Sahar?
Measurement of C-peptide.
No.
Improvement of symptoms affecting
Excellent, Ya Hassa.
cost.
Perfect, Ya Hassa. Improvement of the symptoms if you give glucose. If you give the patient oral glucose or IV glucose, the symptoms will improve. Okay? With these three findings, you will diagnose insulinoma. Of course, this is not definitive diagnosis, final diagnosis. This is just primary diagnosis of insulinoma. Okay, if you give glucose, the symptoms will be improved. Okay, so this is the insulinoma. Okay, so how to know the insulin is endogenous or exogenous? How you know? By C peptide.
Yes, sir.
Yes, by C peptides. Okay. Why C peptide will differentiate between endogenous and exogenous? Why? What is the relation?
Insulin produced by pro-insulin, then the insulin along with the C peptide also will get released. So
Excellent.
only in endogenous part only the C peptide levels will get increased. Not to the we are not giving the exogenous via C peptide so that it won't be.
Yes, perfect. Okay. Clear, everyone? Okay. Next one, yeah, Daya.
Yes, sir. A 30-year-old woman present with general surgical clinic, 1.5 centimeter cervical lymph node and the anterior part of the sternocleidomastoid mastoid. And clinical examination, routine blood test, unremarkable. She undergoes excisional biopsy, the lump as the day case. The histology report reveals encapsulated infiltrative carcinoma with a marked fibrosis and cystic changes within the lymph node. What is the most likely primary pathology? The answer is papillary carcinoma of papillary.
Yes, papillary thyroid carcinoma. Yes.
Carcinoma.
Why, Daya?
The histology report reveals encapsulated infiltrative carcinoma. Sir. So papillary and it is a nodal. We have excisional biopsy of the node was done. So nodal present lymph node metastasis through the papillary carcinoma and medullary carcinoma. So follicular will be through the blood spread. So the encapsulated will be follicular and papillary. So papillary carcinoma will be the.
So here the word encapsulated means what? It has capsule or without capsule?
It has capsules. Encapsulated.
Yes. So I think you are confused in this. Okay. Encapsulated means with capsule. Uncapsulated means without. Okay. So uncapsulated means no capsule. Encapsulated, or you can say capsulated, means there is capsule. This is first point. Okay. So here there is capsule for the tumor. This is one feature of papillary. Yes, this is one thing. What else make you select the papillary? The other thing is the lymph node.
Cervical lymph node.
Cervical lymph node, yes. And the other thing is what? Most likely. Okay?
Yes,
most likely. What is the most likely tumor in the thyroid? Papillary. Full stop. What is the most like means what is the most common. Okay? This is one thing. The other thing is lymphatic spread. The third thing is capsulated. Okay?
Yes.
Okay. So this is and also there is cystic changes and fibrosis and cystic changes also with the papillary. Okay? All these features with papillary. Okay. Why not anaplastic?
Anaplastic will be plus with it is infiltrative. So it will be present with spider and those kind of symptoms mostly.
Anaplastic not come in this age. Anaplastic in very old age, above 70 and female, yes, but above 70. Very old and it's very aggressive, highly aggressive. Okay, so it's not this one. Okay, and also it will cause local invasion, not just lymph node spread. Okay, follicular come with blood spread. Okay, and so it's not common with lymph node. Follicular will not come with lymph node. It comes with distant metastasis by blood spread. Medullary will come with other symptoms as a part of Men's syndrome. Okay, so I will give you a key or a mnemonic to remember the spread the method of spread of all thyroid cancer. Okay? And
Okay.
please focus with this and write behind me. Okay, so we have papillary, medullary, follicular, and anaplastic. Okay, I write the last letter to remember. Papillary, Y, medullary, Y, follicular, R, anaplastic, C. Y for yellow. And yellow is lymph. Lymph is yellow fluid. Okay? So Y, any Y, papillary and medullary, Y, end with letter Y, means yellow, yellow for lymph. Even lymph has Y. Okay? So lymph is yellow color. R for red, which is what? Blood. This one is C, means combined or complex, everything, but mainly local spread. Okay, but can be with lymph, can be with the blood, with the local invasion, very aggressive tumor, the anaplastic one. Okay, very rare, but very aggressive, and mainly in the elder females. Okay, so C, combined, R, red blood, Y, yellow lymph. Okay, this is the method
Okay,
of
sir.
spread of thyroid cancer. Next one, yeah, Daya.
35-year-old man present with severe headache, photophobia, and neck stiffness. Clinic sign positive. Midline lumbar puncture was performed. Immediately to determine the CSF, pathogen is involved. In performing this procedure, which is the first structures, following structures to be pierced by the lumbar puncture needle. Uh, uh, um, A. Anterolongitudinal ligament, B. Arachnoid matter, C. Dura matter, D. Interspinous ligament, B. E. Posterior longitudinal ligament. Option is among the options the first pierced by this interspinous ligament, sir.
Interspinous ligament. Excellent. The best thing you make, Yadaya, is what? You know what is the best thing you said in your answer?
Among these options.
Yes. Yes. Among these options or from this option, the answer is like this. Okay? And this information is a very clear example of new questions, not new information. Okay? They can play with you in this question. Actually, they can play with you in this question. So you need
Okay,
to
sir.
highly concentrate it and focus with the question. And it's not a new question. You know, it's a not new information. Yes, they can change the question. How they change the question? By change some words like what? Which is the first? They can say which is the last, or which is the second. If they need to play more, okay, like this, or they can change the 5 layers, okay, because normally we have how many layer? 9 layers. Sorry, 8. The number 9 is the space, subarachnoid space itself. Okay, so we have
Yes,
eight
yes,
layers, then you will find the space, subarachnoid space. These 8 layers,
yes,
they can't put 8 options, so we have 5 options. Any 5 of the 8 can be put here. Okay, and what you need to do, you need to arrange the 5 related to each other. Okay, and then you will check the stem. They ask about the first, the second, the last, the third, any change they can do. Okay, but you are stable and confident. You know the 8 layers, okay, from the skin until the subarachnoid space. Any 5 layers
yes, sir.
you will organize or arrange, okay, from out inward, from outside inside. Okay, then you will check the stem. They ask about the first or the last. Clear?
Okay, sir.
Hello? Everyone
Yes, sir.
understand this one? Okay.
Clear.
Okay, صح. So, yeah, Daya, can you tell me what are the 8 layers? The 8 layers
Sir,
from out
okay,
inside?
sir. Skin, first layer is skin, sir. Second
Yes.
layer is subcutaneous tissue. Third layer is supraspinous ligament. Fourth is this fourth is interspinous ligament, sir. Then ligament of flavum.
Then,
Then epidural space, sir. Then dura, then arachnoid, subarachnoid space, sir.
excellent, yeah, Daya. Yes. Now you are ready to deal with any changes of the question. Okay.
Yes,
So
sir. Okay, sir.
this is the sequence or the order of the layer from outside until till you find the subarachnoid space. And remember, they can change the options, they can change the word first or second or last, whatever. Okay. In the question, they mentioned meningitis. Okay, so we need to make CSF aspiration for diagnosis of meningitis to check culture sensitivity and the bacteria. Okay, but also they mentioned one test which is called Kernick's sign. You know what is this?
While Kernick sign is while lifting the thighs with supine position.
How you
while in patient with supine position,
yes.
we have to elevate the legs with thighs. Legs.
You will flex the hip and knee at 90 degree.
It's
Then, yes. Then after flexion of the hip and knee, if you need to extend the knee, you can't. You can't. The patient will feel severe pain due to stretch of the meninges. This will increase the pain. This is Kernick's signs. Okay? In case of meningitis. Excellent, Yadaya. Last question for you.
A 26-year-old woman presents with severe headache, photophobia, neck stiffness, among other indications, lumbar function is earned out, CSF is sent to microscopy. Culture shows Neisseria meningitis, predominant cell type in the CSF. Option A, B, basophils, E, B, eosinophils, C, lymphocytes, D, macrophages, E, neutrophils. E, neutrophils. Due to acute infection, neutrophils will be there.
Excellent. Yes. So the predominant cell in acute inflammation here, we need to know this is a case of acute inflammation. So what is the predominant cell in acute inflammation? Neutrophil. What is the predominant cell in chronic inflammation?
Lymphocytes and plasma cells.
Excellent. And the macrophage. Lymphocyte, plasma cell, macrophage. Okay, so neutrophil is a predominant cell in acute inflammation, and here acute bacterial meningitis. Okay, polymorph nuclear leukocyte. If they change the word neutrophil, they can put polymorph nuclear leukocyte. This is the other name of neutrophil. Okay, so in the exam, they will not neutrophil and put the other name, and you will think they change the questions, they change the exam. It's everything is new. It's not new. Okay, polymorph nuclear leukocyte is the same as the neutrophil. Okay, and this is a case of acute bacterial meningitis, acute inflammation, and this is the answer. Okay, guys.
Okay.
Any problem here? Okay. Thank you, Daya. You did also very great. Thank you so much. Who is the second one? Who's the third one?
It's me, Doctor.
Jasmine. Okay, welcome you, Jasmine.
Thank you.
Start, please.
Okay, a 70-year-old woman from a nursing home presented to the emergency department with abdominal pain and vomiting. In examination, she is dehydrated and her abdomen is distended. There is the 3x4 swelling in her right groin, which is non-tender, and there is no cabin pulse. At operation, femoral hernia found. Which of the following lies medial to the neck of the femoral hernia? So here we need to know the anatomy around the femoral ring, and medially to the femoral ring would be the lacunar ligament.
Excellent. Excellent. Lacunar ligament. Again, this part of anatomy, we have a lot of questions, maybe more than 20 or 30 questions related to this area. Every word can come and ask it in exam. Ready, Jassim, to cover this part?
Yeah, I can try.
Inshallah. Okay, so the patient has, as they mentioned very clearly, femoral hernia. Okay, and they need to know what are the relations here. In this part, everything is important as a relation. What is the medial, what is anterior, what is posterior, what is the content. Everything like this. Okay, so as you said, the answer is lacunar ligament, and we are talking about the femoral hernia. Femoral hernia protrude from the femoral ring. okay, through the femoral canal and protrude from the femoral ring. Okay, so we need to know everything about the femoral ring, about the femoral canal, about the femoral triangle, okay, relations of this all. Okay, so let's start about the femoral ring. What are the boundaries? You said medial lacunar ligament. This is the question. Medial neck of the hernia is lacunar ligament. What is lateral?
Yes. A lateral would be the middle compartment of the femoral sheath, which contains the femoral vein.
Excellent, ya Jas. MashaAllah. Perfect. What is anterior?
Anterior will be the inguinal ligament, and posterior will be the pectineal line and pectineal ligament.
Pectineal ligament. Excellent. Excellent. So the other name of pectineal ligament is Cooper's ligament. Maybe they can change. Okay. So posteriorly pectineal ligament or Cooper's ligament. Okay. Okay. And anteriorly inguinal ligament. Okay. So this is the femoral ring. Regarding the femoral triangle, what are the boundaries, ya Jas?
Well, the medial border is adductor pollicis longus muscle. The lateral border would be the medial border of the sartorius muscle.
And the medial border of the triangle by what?
The medial border, yeah, it will be the adductor pollicis muscle.
I not accept this answer.
The medial border of the adductor pollicis muscle.
Excellent. Yes. Yes. This is the perfect answer. Medial border of adductor longus. Okay?
Yeah.
Yes. And the lateral border of the triangle by what?
The lateral border, as I mentioned, is the sartorius muscle.
Medial border of sartorius.
Yes. Medial border of the sartorius muscle.
And the base
these
of
two,
the triangle by?
The base is inguinal ligament.
Excellent.
And these two muscles will make the apex, which is the overlap of the adductor pollicis and the sartorius muscle.
Excellent. Yes. So regarding the femoral sheath,
yes,
boundaries also.
Femoral sheath is composed of two fascias. So anteriorly would be the fascia transversalis and posteriorly by the fascia iliacus.
And the medial and lateral?
It is the well, the two sheaths combines together.
Yes,
and they will
fusion
make
of
the
the two
medial
fascia together. Excellent.
Yes.
Excellent. And it's divided into 4 compartments, right?
3 compartments.
Excellent. Yes, mashallah. Okay. Mention the contents.
So the medial compartment will be the femoral ring or canal that contains lymph and fat.
Yes.
And middle compartment will be the femoral vein, and the lateral compartment would be femoral artery and the femoral branch of the genitofemoral nerve.
MashaAllah, Jason. Perfect, wallah. Okay. Regarding the femoral canal boundaries.
Femoral canal, well, it's so the lateral border will be the middle compartment, the same as we just mentioned. And the medial border will be the fusion of the two the two fascias.
Excellent, excellent. And anterior?
Anterior, I'm not sure. It would be the inguinal ligament or.
Oh, yeah, just this is canal, not ring.
Yeah.
Canal means wall. The boundary will be wall. Canal is part of the sheath, right?
Yeah. Yeah.
What is the anterior wall of the sheath?
So fascia transversalis. Yeah.
Yes, and what is the posterior? Fascia iliac.
Iliacus. Yeah.
100% perfect, yeah, Jason. MashaAllah.
Thank you.
Okay. Next one.
26-year-old man presented to the emergency department with extensive bleeding from his arm after sustaining a glass injury. On examination, there is a 7 centimeter transverse laceration across the anterior aspect of his elbow. On exploring the cubital fossa, you would expect the brachial artery to be so the relation of the brachial artery and the median nerve is lateral and then over it and then medial. So
The artery is lateral.
here the medial
Can you repeat, Jason?
lateral, then anterior. Yeah. So
What is the lateral
the relation
anterior?
of the nerve with, so the nerve is lateral to the brachial artery and then over it and then medial to it.
Yes, excellent. So you
Yeah.
can say simply this mnemonic: the nerve lam the artery. Nerve
Yes.
lam artery. What is lam? Lateral in the upper part, then anterior, then medial. LAM, lateral, anterior, medial to the artery. You need to fix the relation because they will play with you. Again, they change this question many times. They can start with the artery. And here some people can be lost. Artery with lateral or anterior or medial, you know, this is the confusion come like this with the exam stress, with not sleeping very well, okay, with other some questions, difficult questions. So this simple question, you can be lost easily and confused. Okay, so please, you need to know and fix one sentence in your mind, and with this sentence, you can be stable and change and deal with any changes. Okay, so as Abu Omar, my concept is, or my sentence is, nerve lam the artery. Okay, upper part, middle part, lower part. Lower part means cubital fossa. Okay, so you know, this is upper and middle and lower part, and we talk about the nerve. We will not talk about the artery. If they ask about the artery in exam, I will remember nerve lams artery, then artery middle, lateral or posterior or medial. Okay, very simple. Don't make both in your mind; it will confuse you. Select one of them, maybe, and the best one is nerve lam the artery. Okay, and by this mnemonic you can imagine what is the part of the upper or middle or lower part, and also they ask about the nerve or they ask about the artery. Okay.
This question, says they mentioned the artery to be lateral to the median nerve in this case.
Yes, excellent. So here they ask about brachial artery relation to the median nerve. Brachial artery in the cubital fossa. As I told you, we will pick the two words. Where in the cubital fossa means in the lower. Okay? And the artery related to the nerve will be lateral. So answer is C. Okay, guys? Clear for everyone? Please confirm. Keep the mnemonic and you can deal with any changes very easily. Anything not clear? Okay, Jason?
Yes.
Okay, we will discuss other relations, okay, in the same time. We need to discuss other arteries and nerves relation. Now we discussed brachial artery and median nerve, but we have another arteries and nerves. Radial nerve and radial artery, ulnar nerve and ulnar artery. Mention, ya Jason, relations.
So there's a mnemonic from your lectures. Radial nerve is a radial to the radial artery, and same goes for the ulnar nerve as ulnar to the ulnar artery.
Excellent.
So radial means lateral.
Yes, excellent.
Yeah.
So it's like a song. Radial nerve is radial to radial artery. Ulnar nerve is ulnar to ulnar artery. Okay, and the word ulnar in anatomy or
medial.
Medial, yes, and the word radial means lateral. Okay, and in every mnemonic we start with the nerve. Remember, we fix the relation of the nerve to the artery. Even here, median nerve lam the brachial artery. So we start with the nerve. We start with the radial nerve. We start with the ulnar nerve. Ulnar nerve is ulnar to ulnar artery. Radial nerve is radial to radial artery. Median nerve lam the brachial artery. Okay? So every time we start with the nerve and remember the mnemonics. Okay? So what are the boundaries of the cubital fossa, Jess?
So the medial boundary will be the pronator teres muscle.
Yes.
And the lateral boundary would be the brachioradialis muscle.
Excellent.
And these two would make the apex. And
what is the base of the cubital fossa?
there, it's an imaginary line, but I'm not sure between which two bones. Honestly, I can't recall. But I know that there's an.
Okay, between the two epicondyles, medial and lateral epicondyles. This is the base or the base of the cubital fossa. Imaginary line because there is no structure in this area, just imaginary line between the 2 points. Excellent again, ya Jasim, mashallah.
Thank you.
Next one.
Sorry, just quickly, could you go over the borders of the cubital fossa again?
Repeat, ya Jasim.
Okay, so we said the base would be the imaginary line between the 2 epicondyles. Medial boundary would be the pronator teres, and the lateral boundary would be the brachioradialis muscle, and these two would combine and make the apex.
Yes.
Okay, thank you.
Overlap together to make the apex of the cubital fossa, and it will be covered by the skin superficial fascia and this. And okay, this is the cubital fossa. Next question, ya Jasmine.
A 52-year-old man is found to have multiple myeloma. What's called X-ray appearances would be characteristic. So the characteristic features of multiple myeloma are the osteolytic lesions. So the answer will be multiple osteolytic lesions, D.
Yes. So multiple myeloma is a tumor of what? What is the multiple myeloma?
A tumor of beta lymphocytes.
Beta?
I'm not sure. I'm not recalling.
Plasma cells.
What, ya Sahar?
Plasma cells?
Yes, excellent. Perfect. So multiple myeloma is the tumor of plasma cell, or the other name is plasma cell tumor. Okay, the incidence of multiple myeloma common in what? What are the risk factors or common in? This
Elderly.
is the. Okay, Sahar, continue.
Elderly and male.
Excellent. And the black race and usually familial. There is family history. Black race more, okay, more risk, and male and old age. Okay, these are the risk factors of multiple myeloma. There is genetic problem usually. Okay, and it comes with renal failure, hypercalcemia, and Benz-Jones protein in urine. Benz-Jones protein in urine. So this is a primary bone tumor. Primary bone tumor. Okay, and we can say this is the most common primary bone tumor in old age. Okay, there is bone tumors but metastasis in old age, but not primary. So please don't mix. When we talk about primary bone tumor, means the tumor arises primarily in the bone. In old age will be the most common will be multiple myeloma. But generally, if there is malignancy in the bone, okay, the secondary is more common. Okay, the secondary is more common. Okay, but the most common primary is the multiple myeloma. Clear? Hello?
Yes.
Okay, so this is a multiple myeloma, and it will cause bone resorption. This is the tumor of the bone, release of calcium, hypercalcemia, and there is bone resorption. So there is osteolytic lesion in the imaging. Okay, in the skull X-ray, there is osteolytic lesion, which is multiple osteolytic lesion in the X-ray appearance. Okay, Justin?
Yes.
Okay. Next one.
50-year-old woman present with a history of right upper quadrant pain and jaundice. She reports that her urine was dark in color and her stool are offensive and difficult to flush. Which of the following explains the dark urine? So here I'm guessing this is a case of obstructive jaundice.
Yes.
And The reason of dark colored urine will be increase in conjugated bilirubinuria.
So option A.
Yes.
Excellent. But did you revise this part of bilirubin metabolism and jaundice and all this?
Yeah, but sometimes they go not so close.
Okay,
But I can
let's-
try.
Okay, let's revise and cover this part because I know it's heavy for or tough for many students. Inshallah, I will try to simplify as possible to not forget because we need it also in part B, this part, this topic. Okay, so we will revise bilirubin metabolism quickly. First of all, there is hemolysis of the RBCs, whether the normal hemolysis with the aging of the RBCs in the spleen, or if any hemolytic disease, whatever the cause, there is. Now we are talking about the normal physiology. So with the hemolysis of RBCs and destruction in the spleen, there will be release of what? Of the bilirubin, the final product after some steps of hemolysis, not our issue here. But finally, with this destruction, there will be release of what? Of bilirubin. This bilirubin comes from destruction of RBCs. The first bilirubin comes will be unconjugated.
Unconjugated.
Okay, unconjugated, or sometimes they call it indirect. So remember, unconjugated, indirect, negative all, okay? And also it's insoluble, okay? So insoluble, indirect, unconjugated. This is the same features of the same structure, okay? Then this one will go to the liver. In the liver, everything will be changed. Why? It will be conjugated and it will be direct and also it will be water soluble. Okay? Conjugated now. This conjugated, all this will be changed to the opposite. It will be conjugated and it will be direct and it will be water soluble. Then it will go to the secreted with the bile and go to the duodenum, then from the duodenum to the small intestine and the terminal ileum. Until now, step by step, everything is okay?
Yes.
Hello? Some people keep
Yes.
silent. If you have a question, please ask. Don't skip any difficult or confusing part because we will need everything for later discussion again and again. So don't skip. Okay, now we have the conjugated bilirubin where? In the terminal ileum. Okay? Okay. Before this, we need to know bilirubin conjugated with what and by what? You know, Yajasin? Conjugated to
I know.
what?
It's conjugated by the gluconeal transferase enzyme.
Yes. So
But-
conjugated with what?
That I don't know.
Sorry?
I don't know.
You don't know. Okay. Anyone know? Bilirubin will be, the unconjugated bilirubin will be conjugated with what? The conjugation means binding with what? Glucuronic acid. Okay? Glucuronic acid. By what? By the enzyme called glucuronyl transferase. So conjugated with what and by what? Now, okay. Then it will be conjugated and finally it will be in the terminal ileum. What will happen in the terminal ileum for this conjugated bilirubin? You know, Yajasin?
Yes, it will be converted to unconjugated bilirubin again by the gut flora.
Excellent. The bacteria of the flora, bacterial flora, okay, it will make it unconjugated again because this bacteria produce enzyme called protease. Then it will become unconjugated bilirubin, and then another step, it will be urobilinogen. Urobilinogen. Please don't forget this one. So the conjugated will be unconjugated and then will be urobilinogen. Okay? This is the middle of the metabolism. We finished the first half. The second half is more difficult and more important to understand. Okay? Now we will start with the urobilinogen. Until urobilinogen, everyone understand?
Yes.
Hello? Okay. So what is the fate of urobilinogen? What will happen to urobilinogen? Urobilinogen where is the urobilinogen? In the ileum, in the terminal ileum. What will happen? 90% of urobilinogen will be oxidized to form stercobilinogen. So 90% of what? Of urobilinogen will be oxidized to form stercobilinogen. Stercobilinogen will pass with the stool, and this is the cause why the stool is brown. This gives the stool its brown color. Okay, remember, stercobilinogen will pass in the stool, not the urobilinogen. Stercobilinogen. So urobilinogen will be oxidized. 90% of urobilinogen will be oxidized to form stercobilinogen, and this one will give the stool its brown color. Okay, and it will be without any offensive odor. The presence of stercobilinogen prevent the offensive odor of the stool. Okay, and it will be brown color. This is normally. We are talking about normally. The 10% of urobilinogen, what will happen for the 10%? It will be reabsorbed from the ileum, with the ileum already absorptive space. The ileum absorbs the nutrition and the food, okay, and the nutrient. So 10% of the urobilinogen in the ileum will be reabsorbed, okay, and enter the blood. Someone has back noise in the mic. Please mute your mic. I don't know who, but okay. So 10% of urobilinogen will be reabsorbed in the blood, and after it will enter the blood, it has two pathways. Okay, most of it will go to, again, the liver. Most of the absorbed urobilinogen will go to the liver and repeat the cycle again. Okay, and small part will not go to the liver. It will go to the kidney. Okay, it will go to what? To the kidney, secreted in the urine. So this is normal. Okay, normal in the urine to find urobilinogen. Okay, and this urobilinogen normally found in the urine will make the urine to be yellow color. Why the normal urine is yellow? Due to presence of what? Of urobilinogen. This urobilinogen come from where? Come from the terminal ileum, absorbed, and after absorption, most will go to the liver and repeat the cycle again and again, and small part of urobilinogen after enters the blood, it will go to the kidney, secreted in the kidney, in the glomeruli, and makes the urine to be yellow color. Okay, guys? Hello?
Yes.
Okay. This is the full bilirubin metabolism normally. Okay, what are the abnormal? The most common abnormality in our exam is obstructive jaundice. What is the obstructive jaundice? As we know, the step of conjugated bilirubin from the liver to the duodenum is closed. So no conjugated bilirubin in the terminal ileum, no urobilinogen, no stercobilinogen, no absorption of urobilinogen to the kidney, no yellow color. You see, we close the way here. So all other steps will be no obstruction of the conjugated bilirubin from the liver to the intestine. All what we mentioned will not happen. Okay, why? Again, the conjugated bilirubin from the liver will not go to the terminal ileum. If it will not go to the terminal ileum, no urobilinogen. If no urobilinogen, no stercobilinogen, no brown color stool. Okay, no reabsorption, no yellow color urine, because no urobilinogen in urine. What will happen? Instead of all this, no, what will happen? There is increased conjugated bilirubin in the blood. Why? It will be accumulated in the liver, then it will go to the circulation. Okay? After it will go to the circulation, it will be distributed all over the body. So it will be deposited under the skin, causing yellow color, causing itching. Go to the kidney and secreted in the urine. If the conjugated bilirubin go to the kidney, secreted in the urine will be what? Dark color. Okay? Why is the urine dark color? Due to presence of what? Of conjugated bilirubin. Okay? Where is this? Yes. Increased conjugated bilirubinuria. The conjugated bilirubin come in urine. So conjugated bilirubinuria means conjugated bilirubin in the urine will make the urine to be dark color. So the patient has urine is what? Is dark in color. And the stool is what? Is offensive. And what? Difficult to flush, and it should be pale. Why they didn't mention pale stool? Should be pale stool. Okay? The stool here will be pale stool. Why pale stool? Because there is no stercobilinogen in the stool. Okay? And there is jaundice because deposition of the conjugated bilirubin. Okay, so they ask specifically why the dark urine due to presence of what? Of conjugated bilirubin. Why? Because conjugated bilirubin will not go to the intestine and it will be increased in the liver, released into the blood, secreted by the kidney, make the urine to be dark colored urine. Okay, guys?
Yes.
Anyone confused? Anyone lost in something? Any step difficult? I hope it's clear. Hello?
I just want to ask, can they ask, what enzyme conjugates bilirubin and what is used to conjugate bilirubin?
Yes, all this can
I
be
never
asked.
studied that before.
Yes, glucuronic acid and glucuronyl transferase asked it before. Okay? All what I mentioned to understand. About the question, you will deal with the question if they change. But you need to know what is the basic physiology, to know what is the abnormalities. And I think it's clear after this discussion. Okay, guys? Okay, what is another question? What is the daily amount of bile, ya Jassim, you know?
I think 800 cc to 1000.
Yes, to 1,000, yes. 800 to 1,000 milli per day. Okay, this is also another question asked. Okay, last question for you, Jassim.
A 45-year-old man present with backache and leg pain due to collapsed lumbar intervertebral disc. The pain, which is aggravated by coughing and sneezing, radiates the lateral aspect of the foot. On examination, there is weakness of the plantar flexors of the foot, which nerve root is likely to be involved. So when there is a weakness of the plantar flexors of the foot, this is the function of S1, which is responsible for plantar flexion and foot eversion. So S1, option D.
Excellent. S1 is the most important single nerve root in our exam. Remember, S1. This is the most, I know, in this sheet, in Fawzia sheet, we have 3 questions about S1. Can you imagine? In the same exam, 3 questions about S1. This is the first one, okay? So when we meet the other 2 questions, we will skip or not go details because already we will discuss now. So again, S1 responsible for ankle plantar flexion by the gastrocnemius muscle, okay? And also ankle reflex. This is the S1 root affected, okay? Actually, all dermatomes and roots important to remember, but this one of the most important one. Okay, Jassim, thank you so much, Jassim. MashaAllah,
Thank
you
you.
did very, very great, wallahi. So guys, we have a break for 5 to 10 minutes. Please, if someone needs to do something within maximum 10 minutes, maximum, okay? Then we can restart again. First, to make the record not too long, now it's 2 hours, and also to give some break if you need to do something within maximum 10 minutes, and we will restart. Okay, guys? So if you like, don't leave the meeting. Just stay and mute your mic and come before 10 minutes. Okay? Okay. And the fourth one, participant be ready to start directly after we come. Okay.